Good morning, everyone. At the outset, I'd like to thank Dilip sir for giving me this opportunity. This is, I believe, it's my fifth occasion to stand in this device update. So I was assigned the topic of discussing about the future of CSP in the next 5 years. I believe it is bright, and so only I'm here now. So what we have learned in the past 5 years about conduction system pacing, we still believe that his bundle pacing is the most physiological form of pacing, but it has its own limitation. Left bundle has come as a salvage procedure, and it provides excellent long-term stability. But the only issue with left bundle is to differentiate between the true conduction system pacing versus LV septal pacing. We also learned that during follow-up, a significant number of patients, nearly about 4 to 4.5% of patients, can have a loss of R wave during follow-up. And these patients are at risk of developing a new onset LV dysfunction, which was seen in around 3.75% of our cohort, which involved 400 patients. So it's very important to monitor these patients regularly in device clinic, both with ECG as well as clinical and echocardiographic assessment. We also have learned about the long-term durability of these leads, be it styler-driven leads or lumenless leads. So we need to carefully monitor these patients because these leads are not meant for deploying it deep inside the septum. In fact, this was a collaborative study involving close to 8,500 leads, which had shown that the fracture rate or distal conductor fracture rate is more with styler-driven lead as compared to lumenless lead. So overall in the world, there were 2 lead fractures reported from lumenless lead. One is from my center, another from Dr. Vijayaraman Sir Center. Apart from that, there are no episodes of lead fractures from lumenless lead. So what we can expect in the next few years, we can expect some improvement in implantation tools, better criteria to confirm the conduction system capture, and imaging modality, which is an upcoming one to facilitate conduction system pacing, combining the technologies of defibrillation therapy and leadless therapy with conduction system pacing. And we need more and more randomized trial to bring it up as a class 1 indication so that it can be used routinely. We know we all started with C315 sheath and 3830 lead, but we have now delivery catheters both deflectable as well as fixed from all our industry partners, and probably in the near future we'll be having a dedicated conduction system pacing leads meant for capturing the left bundle. And probably that will definitely improve the procedural success rate. So there is still a debate of discussing about the extendable helix versus fixed helix lead. Probably in the near future, who knows, maybe all the industry partners, they may be coming out with the styler-driven fixed helix lead. Probably that is the way to go. And as I've discussed, the confirmation of the conduction system capture versus differentiating it from a left bundle branch left ventricular septal capture is very difficult when it comes to left bundle branch pacing, but it is quite easy when it comes to his bundle pacing. It's like differentiating the cat from the tiger. You can easily differentiate his bundle pacing from myocardial pacing. But for left bundle pacing, the QR pattern, which is the so-called classical pattern of left bundle pacing, can be seen in 40% of LV septal pacing. So we need to have a simplified but a better criteria which should differentiate LV septal pacing from left bundle pacing. So this is the criteria which we always adapt, and we are almost like 99% of the time will be correct by following this simple criteria. So one is the QR pattern or RBBB delay pattern, which will be seen in majority of the patient, not in all patients with the left bundle branch pacing. But this should be taken as one criteria. Apart from that, we need to have one other additional criteria to confirm that we have captured the bundle and not the myocardium. So this can be a short and constant LVAD or an output dependent transition in QRS morphology. I was talking about the imaging. This is one paper which was published a couple of weeks back in Heart Rhythm, where they have where they enumerated the anatomy of conduction system from the CT angiographies. They have used fixed landmarks, and based on the activation pattern and the QRS morphology, they have demonstrated the anatomy of the conduction system with the help of CT angiography. So in fact, we had a study on CT angiography where we have done a CT angiogram at implantation and at 6 months follow-up. So we got to know about some important things which happens at the lead tip inside the myocardium during 6 months follow-up. So almost like 94% of the patient had consistent conduction system capture, but nearly 75% had a stable lead which moved at less than 1 millimeter. But there were certain leads which were deployed little inside the myocardium, retracted back, and there were some leads which migrated little into the myocardium, touching the LV cavity. So these three group of patients, though there was some micro movements, there was a consistent capture, but those leads which got dislodged by more than 2 millimeter, so remember this magic number of more than 2 millimeter, this is what we got from our CT angiography study. These patients had a loss of R wave or loss of left bundle branch capture. So when we retrospectively went there and analyzed the histopathology of or histological specimen of a conduction system, we got to know that the thickness of left bundle fibers was around 1 to 2 millimeters. This is all postmortem studies. So this is matching with our CT angiography study. So when there is a lead displacement by more than 2 millimeter, then definitely there will be a loss of conduction system capture during follow-up. So this happens in nearly 6% of our patient. So we collaborated with the Italian group. We sent our CT for analysis, and we got to know about this beautiful picture of reconstruction of conduction system anatomy with the help of CT angiography. This is all post-procedure CT angiography. You can see the white dots, which is nothing but the pacing leads. So it is in the trunk, it is in the anterior fascicle, it is in the septal fascicle. So this helps us to confirm that we are into the conduction system. So we are going to go one step ahead by doing the CT angiography before the procedure and integrate it with our specifically integrated fluoroscopic algorithm, so that we can navigate the conduction system during implantation, and that will facilitate and that will help us to reach either the main bundle, posterior fascicle, or anterior fascicle, wherever you want to go. So this is purely an experimental one, which we expect that the results will be coming in another 1 year. So if you are going to get a good result with that navigation system, I believe the conduction system pacing will be still more easy in the upcoming years. The another important thing, my all-time favorite cardiac MRI, it is probably a luxury to get cardiac MRI for all the patients, but it is always an essential one to determine which mode of therapy to be given or offered for a patient with a heart failure. So when you have a scar completely encircling the infralateral wall, I believe the CS leads will not work. You have to go for a CSP-based strategy. On the other hand, if you have a septal scar, based on the distribution of the septal scar, you can decide about a conventional left bundle pacing, a conventional CSP, or a combination of both. For example, this particular patient had a scar. You can see anything white in the cardiac MRI. After giving gadolinium, after 20 minutes after giving gadolinium, that can be considered a scar. You can see in the upper picture, the superior part of the septum is scarred. So I positioned my lead in the mid part of the inferior septum, where I could get into the left bundle, and you can give the beautiful appearing QRS. So in this way, if you have a pre-procedural MRI demonstrating about the distribution of the scar, definitely that will help us in deploying the lead at the right area and to decide about the modality of the therapy. So combining two therapies, so defibrillation therapy with the CSP, though these days we have an experimental dedicated defibrillator lead which can capture the conduction system, but as of now there is no commercially available lead. So we have used the Abbott lead to deploy it directly in the left bundle area, but before that we had to do certain homework so that we can, when you are doing something new, you have to be very precise and be specific that it is not harming the patient. So we had analyzed all those patients who had undergone LOT ICD and LOT CRTD in our cohort and demonstrated that the sensing property of the left bundle lead for ICD function was appropriate. So almost 90% of the patient had appropriate sensing of arrhythmias from the left bundle lead, which is connected to the ICD chamber. So only in 10% there was an inappropriate detection. That happened purely because of T-wave oversensing, and that too with a particular device from Medtronic. So this we got to know that, okay, so this is working good, so the sensing will not be a problem. So we can safely deploy the ICD lead directly into the left bundle zone. So we have to discuss about the pros and cons. Advantage, obviously, you are reducing the number of leads, and you can directly deliver the ATP into the conduction system. That is going to have a better effect of termination of the arrhythmias. You are going to reduce the injury, valvular injury. But on the other hand, it is going to be a bulky lead into the myocardium. The delivery catheters, we don't have a specifically designed catheter. We have to keep in mind about the ICD coil length. Different vendors have different length. You don't want the coil to float in the atrium. That is going to produce atrial oversensing. And the patient needs to get appropriate therapy at the appropriate time. So we have chosen this DF1 Durata lead. So these are the criteria which actually made us to choose this DF1 Durata lead. It is a smaller size lead as compared to other ICD leads, 6.7 French. It goes easily into the 10 French locator 3D sheath, and it has an IS1 port which is compatible with the helix locking tool, and it provides an option of future lot CRT upgrade. Suppose if there is a micro dislodgement, since it is a DF1 PG, we can always use one more lead and connect it to the DF1 port. So this is how we prepare it. It is nothing new. You have to deploy the lead in the table itself, deploy the helix in the table itself with the help of helix locking tool. Then you take it into the sheath, deploy the lead by continuous spacing method, and once you reach the area, you will be able to demonstrate all the capture confirmation criteria. So once it is confirmed, you have to be little careful in removing the delivery sheath, because it's a very snugly fit sheath. The sheath is 10 French, the lead is 7 French. So you have to be very careful. I tend to keep the stylet till the septum and then remove the sheath. And the sheath removal will be little rapid to avoid micro dislodgement. So what we have shown was nearly 62% of the patient had a procedural success. The failure occurred because of a cheesy septum, and 2 because of atrial oversensing. Only in one patient we could not deploy the lead because of fibrosed myocardium. That too we'll get to know if you do a pre-procedural MRI. But the main important thing is all these patients received a DFT test on table to confirm that the arrhythmia will be appropriately detected and appropriately treated. So leadless technology, we believe in the future it is all going to be a leadless with conduction system pacing to provide physiological activation. That will reduce the number of wires crossing across the tricuspid leaflet, and hopefully it will improve the battery life as well. So this is in the pipeline. Every single vendor is working on it. Probably in another 5-6 years, we'll be having at least one of the industry partners coming out with a leadless left bundle branch area pacings. So we not only target the ventricles, but we also target the atrium for providing resynchronization. So Bachman bundle is one good thing which can be easily approached. So it travels on the superior aspect of the atrium from the SVC-RA junction towards the superior limbus of the fossa ovalis. It can be targeted anywhere along its course. And there is a dedicated sheath, we call it as a C315 S5 sheath from Medtronic, and the 3830 lead, which is used for conduction system pacing, can be used for doing a Bachman bundle pacing. So you have to move between RAO and LAO to make sure that you are capturing or entering into the Bachman bundle and not into the aortic route. So trials are very important. We need a lot of randomized trial to show that the conduction system pacing is not inferior or in fact superior as compared to a biventricular pacing. This is a slide I borrowed from Vijayaraman sir. I was very happy to see one of our study included in 2023 as a landmark trial for a conduction system pacing. And this is in the future. The future is definitely bright. So we can see a lot of randomized trials in Europe, in China, in US being done. The largest one is going to be the left versus left. Close to 2,500 patients are getting enrolled. The study is already on. Probably in another 2 years, we'll get to know about the results of this study. And we believe the conduction system pacing is going to work better than biventricular pacing for patients with heart failure. And probably in the next HRS guideline, we may even get a class 1 status for patients who want to get a conduction system pacing. Thank you.
There was a kind of Medtronic is working on 4.1 French ICD lead. So how about this 6.3 French ICD lead from Abbott going in? If you try for multiple times, 3-4 times, do you see any chance of substantial injury to septum and some of the perforators, vessels, and injury to the septum.
Yeah, so that dedicated, obviously anything dedicated for doing a post procedure will always be better as compared to the already existing leads. So Medtronic is working on a dedicated 3030D lead, omnisecure lead, which is going to get into the left bundle. The studies on septal pacing has done remarkably well. And there are certain pros and cons about the lead. Pros is obviously it's a small size lead. You can go for multiple attempts, but the coil length of the lead is going to be longer than the ICD lead. I believe it is 6.5 centimeter as compared to a 5 centimeter from the Abbott lead, and the sensing polarity is going to be integrated bipolar with the Medtronic as compared to a true bipolar with the Abbott lead. So I think these things matters, and we're waiting for the results of leadless LBBP study trial. We don't know how the ICD lead is going to get accommodated inside the right ventricle and how they are going to solve the issue of atrial oversensing, especially with a long coil and an integrated bipolar sensing vector. But otherwise, dedicated lead is going to work really well. As far as the Abbott leads are concerned, we have done now close to 12 cases, and there was not much of issue in damaging the septum or injuring the coronary artery. So far, we have never damaged or created any VSR or had any coronary artery injury, though we had failures in 2-3 cases because of septal issues. But yeah, like you said, we cannot go for a multiple attempts as this 3830 lead, so we have to be more precise. So as we do a pre-procedural MRI, we tend to measure the septal length from the tricuspid leaflet to the apex. Since I want to deploy that 5 centimeter of coil inside the right ventricle, my primary approach is the left posterior vesicle, not in the trunk. So once I deployed it in the trunk, I had atrial oversensing issue. That case was declared as a failure case. So my approach is to deploy the lead in the posterior vesicle with majority of the coil. So it is another big advantage is it's a true bipolar. So majority of the coil, if it's inside the tricuspid leaflet into the right ventricle, that solves the sensing problem.
Can I have?
Yes, sir.
Regarding the localization of the LVV area, which one would you prefer? Is it CT angio or MRI for the exact localization of your point?
So for on table, we can go by anatomical and electrocardiographic parameters. So CT angio and MRI is for assessing the septal morphology, how we are going to get a procedural success or procedural failure. But for localizing before deploying the lead, so we have to see the septal thickness just before getting into the table, and we have to see the electrocardiographic parameter at the site of implantation. So all we have to do is know about the His bundle location, either with a quadripolar His catheter or with the hump of that TPI catheter, the hub corresponding to the superior aspect of the tricuspid leaflet. Go 1.5 centimeter below that hump, pace map, and see whether you have a W pattern and a discordant QRS in AVL and AVR. Then you can deploy the
Would you
lead.
like to wish to have the CT or MRI as a pre-procedure protocol
Yeah.
each and every case? Would you like
So
to have?
for LV dysfunction patient, for any patient coming for a heart failure device therapy, I believe MRI is the best tool because it is not only going to give us about the scar distribution, but also it gives us an idea about deciding to choose ICD. If there is no scar, probably the ICD may not be required, and to prognosticate the patient also. If there is an extensive scar like it happens with sarcoidosis or any form of infiltrative cardiomyopathy, I don't know whether the CRT-D will really work or not. Rather, it's better to send the patient for a cardiac transplant. So I believe MRI is better in terms of prognosticating the patient and deciding about the device therapy in patients with heart failure.
There's one question, and I'm just wondering how on CT angio it is so authentic that we are looking at the fascicles and the kind of bundle
Yeah.
because when we do a CT for structural heart intervention like TAVR and all, we do see membranous septum, but we don't get any idea about the conduction system. So what do you feel that is very authentic, and how could they do that?
Yeah, so that's what we are working on. It's all like experimental studies. This is the first ever study published on anatomical reconstruction of conduction system based on CT angiography. Just published a couple of weeks back in Heart Rhythm. And we are closely working with that same group in validating the data. So we are collecting large CTs, post-procedural CT, and comparing the electrical parameters as well as the anatomical parameters. For example, if the CT says that it is in the conduction system, then we have to see the electrical parameters, whether it is really captured or not. So the preliminary studies were good. So whatever CTs we have done and we have compared, it was really good. So, but it's like an AI thing. So we need to give more and more input to validate that it is a correct output. So it's still it is in the experimental stage. But once you have demonstrated that it's all based on fixed anatomical landmarks and the activation of the electrical impulse at that particular site in reference to the QRS, it's almost like a 3D mapping. So once you validate this thing, once you validate this thing, and probably it will be easy to integrate into the fluoros system, and you will be able to see the left bundle in front of your eyes just in the fluoro screen. You just have to go there and deploy the lead.
Perfect. So thank you, Shunmuga, for your wonderful presentation. And if there are any other questions to Dr. Shunmuga? If not, then we can move on with Dr. Claire's presentation. Dr. Claire is there? Is online? No.
I have
We have
one more
lost him?
talk.
Achha.
I have one more talk. I'll complete this now, sir.
Yes. Arun has to catch a flight, which is he has to board at something on 12:25. So what we do is, we can go ahead with the assess your presentation, and then Arun will present. Yeah.
Disconnected. Abhi mera ye.
Okay. Thank you for your excellent presentation. I just want to ask one question to you. Regarding the integrating the conduction system pacing and the defibrillator together, do you think like if whenever the patient gets a shock, can the LB pacing, the capture loss can be there or not?
Yeah, it's a good question, because every shock is associated with myocardial damage. So that's an important thing which we have analyzed. So the patients are getting regularly followed up in the device cleaning. We do, as a protocol, 6 months fluoroscopic analysis. Though we can get the electrical parameters from the pacing parameters as well as the pace QRS morphology, but we want to see it fluoroscopy as well. So every patient will get a 6 months fluoroscopy just to make sure that the lead is in the same position, and the electrical parameters will be checked at every instant. And fortunately, the first case was done in last January. It's almost now 1 year now, and none of these patients had a change in pacing parameters nor in defibrillation impedance during follow-up. So.
And sir, like any of those patients have got ICD shocks, and after shock, has the parameters changed or not?
No, that's what I'm telling. So these patients, I think one or two patients had received shock and ATP, and all these were successful. There were no unwanted shocks, and there were no episodes of syncope despite giving shocks, and the pacing parameters, both in terms of capture threshold as well as shock impedance, were the same as compared to the baseline parameters.
Thank you, sir. Thank you.
So SS, you can continue with your next presentation.
So I think it's another important thing. Conduction system pacing, are we in the prime time? So these are my disclosures. So clinical implication of conduction system, I'm not going to talk about the implantation technique and capture confirmation. Rather, I will be more clinical. So these are the two important areas where conduction system pacing works. One is bradyarrhythmia, symptomatic patient, another patient with a heart failure and wide QRS. So you have learned over the past 40 years that the RV pacing has its own limitation. There are a certain group of patients, roughly around 10%, can develop pacing-induced cardiomyopathy. The number varies depending upon the definition which you are going to use. And the CSP has been suggested as one good alternative modality for treating as well as preventing pacing-induced cardiomyopathy. So in brief, the conduction system pacing involves deploying the lead in the his bundle or in the proximal left bundle or one of its fascicles. We know the pros and cons of his bundle pacing, though it is considered as the most physiological form of pacing. It's associated with high thresholds, need for redo procedures, and premature battery depletion. In almost 10 to 15% of the time, you may not be able to correct the distal conduction system disease. The left bundle came as a rescue, but the only issue as far as the current scenario is concerned is to differentiate left bundle branch pacing from LV septal pacing. So once the patient develops pacing-induced cardiomyopathy, so there is no way you have to keep the patient on the same right ventricular lead. You have to go for a biventricular pacing, or more commonly in our center, especially when you pick the patient at the early part of the natural history, we tend to remove the right ventricular lead, put a left bundle lead. So we know the limitations of removing the old RV lead. If it is a old lead, we may have to use an extraction tool and sometimes you may end up in doing a fibroplasty for a stenosed vein. All we do it to change the QRS on the right side to a beautiful appearing QRS on the left side. And needless to say, once you have a resynchronized activation of the ventricle, this being a purely iatrogenic problem, because you're going to rule out all other possible causes, the patient will have normalization of the LV function. So remember, you have to intervene probably at the early part of the natural history once the EF falls below 50%, because as the patient gets older and older with the advancing natural history, there may be fibrosis inside the heart, which will prevent the reversal of the LV function in this patient. So it is always better in the medicine that prevent the complications from occurring rather than treating it. So we have analyzed our own data of RV pacing versus his bundle pacing versus left bundle pacing. Clearly, conduction system pacing has shown a significant improvement in LV ejection fraction as compared to a baseline value. And those patients who had a low LVEF with the AV block, the typical block HF population, had also shown improvement in LV ejection fraction as compared to a fall in LV function in patients who received a right ventricular pacing. So we have now meta-analysis of all the available trials which clearly shown that the incidence of LV dysfunction, heart failure hospitalization, as well as atrial arrhythmias are less in patients who received conduction system pacing as compared to left bundle pacing. Now comes the important question: can pacing-induced cardiomyopathy occur after conduction system pacing? So this is the most important question to answer, because in fact it's a difficult question to answer, because not all QR in lead V1 are considered as left bundle branch pacing. So you need to validate the statement of conduction system capture first before analyzing the incidence of LV dysfunction in patients with conduction system pacing. These 400 odd patients from our center are all those who had a conduction system capture, who had either baseline normal LV function or recovered LV function from the baseline LV dysfunction. So we have found out close to 3.75% of the patient had a new onset LV dysfunction, and fortunately the first three reasons you can see all are reversible. The idiopathic reason which we got was seen in only 0.45%. We have seen only in 2 out of 400 odd patients who had really an unknown cause for occurrence of LV dysfunction despite consistent conduction system capture. So this clearly re-established the fact that conduction system pacing and ensuring the capture of conduction system pacing during follow-up is very, very important. As far as the heart failure is concerned, I don't want to discuss a lot of trials, because already Dr. Arun had described about the trials which I had published so far. This is one of the largest one, which was published by our group in JAC last year, comparing 1,700 patients with the biventricular pacing versus conduction system pacing. This is another very important study from the Chinese group, where they have shown that the LOT CRT is much better than BIV CRT for IVCD groups. This, I believe, it's most important study, because we don't have much therapy for IVCD group of patients. But when you combine the left bundle with a CS lead, it's going to produce a superior outcome, both in terms of electrical as well as mechanical performance. Not only it is going to give reduction in heart failure hospitalization, but also it reduces the new onset atrial fibrillation, new onset ventricular fibrillation, and reduce the number of electrical shocks in patients who had already established VT when you compare the two different modalities, BIV pacing versus conduction system pacing. So it's a very important question to answer about the need for AICD. There are a lot of debates occurring about the importance of or the need for adding ICD lead in patients with underlying non-ischemic cardiomyopathy. In patients with ischemic cardiomyopathy, there is no doubt you have to go for an ICD-based strategy, whether you are putting a CS lead or not, or CSP lead or not, but ICD is very, very important when it comes to ischemic cardiomyopathy. But when it comes to non-ischemic cardiomyopathy, especially when the patient has a typical left bundle branch morphology, it's rather a difficult question. So we tend to categorize the patient based on cardiac MRI. I love doing cardiac MRI for patients who are coming for a device therapy for heart failure, and we categorize the patient based on the MRI scar burden. So when it comes to ischemic cardiomyopathy, it's all ICD-based strategy. The patient will get a CS lead depending upon the correction of QRS morphology. I mean the correction here based on the LVAT. So when I get a good LVAT of less than 100 milliseconds with a QR pattern with confirmed left bundle capture, I believe that is sufficient. I still narrow down the QRS with the help of a native AV fusion. On the other hand, if my LVAT is more than 100 milliseconds, or if I am not correcting the QRS morphology, or if the LBBB correction is incomplete because of peripheral disease, I tend to put an additional CS lead. So with this strategy, we have done our Madurai LBBP study, where we have shown that when you are risk categorizing the patient based on MRI, the survival rate is really, really good. And those patients who had a high scar burden had poor cardiac events during follow-up. And in those patients with a nearly zero scar burden, they have almost 80% normalization of the LV function at the end of 12 months follow-up. This 80% is a huge number for patients with heart failure, because we tend to reduce the heart failure drugs in almost like 25% of the patient. They even stopped the medication, even the beta blockers they were not taking. So it's an important question to answer. Are we in the prime time to use CSP for all patients? So I go by probably in a safer way to enumerate 4 important categories where CSP can be easily advocated. One is those patients who need a committed ventricular pacing, meaning that the pacing burden is going to be more than 40%. As an alternative modality for CRT, if there is a complete QRS correction, where you can just put up a dual chamber left bundle branch pacing, LOT DDD, or LOT ICD if they need an ICD based strategy. If incomplete QRS correction, probably a LOT CRT based strategy will be good. Pacing induced cardiomyopathy, especially when you are doing it in early part of the natural history, you just have to extract the RV lead, add the left bundle lead, use the same dual chamber pacemaker. Another upcoming indication, AVJ ablation. We know the predominant AFib population in our country is rheumatic, and the rheumatic AFibs is not going to go anywhere. It's going to stay inside the left atrium or in the right atrium. So it's very difficult to ablate and get a curative treatment for AFib. Rather, we can knock off the AV junction and put a left bundle lead. And with the left bundle lead, we don't have to go for a backup RV pacing lead itself. So that is going to be a one-stop solution for patients with a chronic rheumatic AFib with poorly controlled ventricular rate. Remember, there is one important historical, I should not say it is a historical one. So rather, every electrophysiologist, rather every conduction system pacing implanter should be aware of this is-bundle pacing, because we know some strategy in the lead may not go inside the septum. So this was one case which I've encountered recently, just 3 months back, where the patient was referred for management of chronic AFib with dilated atrium with a bilateral SVC, and we could not just deploy the lead inside the septum for some reason, and I had to go for a rescue is-bundle pacing. Unfortunately, I could get a quick correction of QRS morphology with this beautiful non-selective to selective is-bundle capture, and you can see the good, beautiful is-bundle potential on the pacing lead as well. So you need to know the alternative strategy itself. So just learning left bundle alone is not going to be sufficient for treating patients with heart failure. You need to know about the nuances and experience of is-bundle pacing itself, so that you will be able to give a complete solution for patients with heart failure. Thank you.
Any questions, comment, Arun, Praveen?
Yeah, first of all, we should congratulate Shunmuga for his wonderful work that he's been pursuing on this field. Is actually most of the publications are being coming from his group. So two queries.
Okay,
yeah, two queries. One is since one of the most important predictors of new onset LV dysfunction after conduct system is loss of conduct system capture. Are there any work on any device algorithms which look at auto capture? What I'm meaning is all the auto captures are EGM based till now to look for the capture of the myocardium alone. Are there any device algorithms which are coming up in the pipeline which looks at specific conduction system capture on the follow-up, which tells you on follow-up, like on the BIV you say that 98% is BIV. On your follow-up of your conduct system devices, they say that, okay, this much is CSP, this much is RV pacing. How are there any algorithms being built on that lines, and what are the thoughts on that?
Yeah, excellent. Actually, this is very important, especially with the future is more of a conduction system pacing based strategy. So yeah, a lot of algorithms are in pipeline, especially to look for the LVAT rather than the QRS morphology. We know the QRS morphology is going to be different based on the fusion pattern, but I think LVAT is the one which is going to be the important one. So there are algorithms which is focusing on the LVAT to be monitored during follow-up and to tell us whether the patient is getting the really left bundle pacing captured or not. Because it's not like a pacing spike delivered QRS generated is equal to left bundle branch pacing. So not only the loss of R, even you can see the second point which I mentioned was suboptimal AV delay. So especially when you get a dual chamber pacemaker and the left bundle branch block with the patients with the baseline 1:1 conduction, when they had a shortening of PR interval during follow-up, it will result in pseudo fusion. Again, the patient is going to develop a heart failure. So it is very important to monitor the capture of conduction system. There are algorithms which are in the pipeline which Medtronic is working on. And definitely in the future, we'll have all the devices which have an integrated algorithm to monitor left bundle branch pacing. And in the future, there may be even a left bundle branch pacing pulse generator, which can give us all the specific algorithms.
Yeah, because we need to look at the EGM. What all we're saying is all on the ECG, which we might be monitoring once in 6 months. Or if they periodically do also, we don't know at one finite point of time whether he has captured, another time he's losing. So we need to have on the EGM, all these criteria won't matter. Your QR, your LVAT, nothing comes on your local EGM from the lead. So local EGM from the lead, how can it predict
Yeah,
an
so
LVAT?
I don't believe in monitoring the local EGM alone. Rather, I would go by doing a unipolar pacing, not a bipolar, but unipolar pacing at high and low output. Because EGM varies depending upon the filter pattern which
But
you are
for the
going to
device
use.
to see, device cannot see the paced QRS. Device can only see the EGM.
Yeah, no, that's what. So the EGM, whether it is in the mid septum or in the deep septum, unless it has perforated in, so you will not have a change in EGM morphology as compared to the baseline, because it's not like a template which is going to register it for a long time. Even if there is a micro movement, the EGM will not change, but only the QRS morphology will change. But definitely, so in fact, we are a part of trial which with a Medtronic to bring out these things. I cannot disclose much. So where we are going to monitor the QRS morphology during follow-up to confirm that it is all conduction system capture, not myocardial pacing.
One final question. Have you had instances where there is a septal infarct on follow-up and loss of conduction system capture purely because of an ischemic etiology? Because we see that in the CRT arena, but we never see of that being talked in the conduct system arena, although we see septums getting infarcted much more than the lateral walls.
So we had seen the other way, like infarcted patient, inferior wall infarcted patients, his bundle pacing done with a wide QRS, regenerating the pathological Q waves, old inferior wall MI, DCM, LBVB, left bundle pacing done, regenerating the old infarcted Q waves, and left bundle pacing patient getting inferior wall MI, but still with a consistent capture. So I have not encountered any patient with a massive anterior wall MI after left bundle branch pacing and loss of follow-up. Fortunately, I believe it should not happen. But yeah, these things has to be kept in mind, because when you have scar in and around that left bundle lead, so definitely it is going to change the QRS morphology and capture threshold and final outcome as well. So that is the importance of following this patient carefully in the device clinic, not with the satellite monitoring, remote monitoring devices, where you will not be able to adjust the settings and assess the patient's clinical status. It's important to see the patient at least once in 6 months or once in a year in the device clinic.
Unipolar left bundle pacing or deep septal pacing, along with the active can giving the far field ECG, and that you can detect that there is LVAT is below 70 or 80 milliseconds. That might be the way to detect that whether left bundle pacing is occurring or not.
Yes, sir, exactly. So exactly. I think LVAT should be given the utmost importance when it comes to left bundle branch pacing.
I think, thanks, Shunmuga. And a quick one, before Arun starts his presentation, he has to catch a flight. All the studies have shown better synchronization with conduction step pacing as compared to BIV. But I still feel this is a complementary. LOT CRT is the way to go. One of the studies showed that there can be 25% of the patients they may have fascicular disease, and you may not get a classical narrowing and QRS shortening and synchronization with conduction system pacing. Do you feel this 25% data is overinflated? We have seen quite a less number of patients. If we insist that we'll do conduction system, 95 to 98% chance it is correct. But there are studies showing 25% of cases in which conduction system pacing is not possible. So what's your comment
So
on
the
that?
25% is a huge number. I think that is not, rather you can talk in terms of ischemic cardiomyopathy and non-ischemic cardiomyopathy. I believe non-ischemic cardiomyopathy, the correction rate is going to be as close as 97 or 98%, because it is all the block will be in the proximal bundle, and the distal fascicular involvement is very, very rare. But when compared to ischemic cardiomyopathy, the success rate varies depending upon the population which you are going to improve, including predominantly anterior wall MI, inferior wall MI. There the success rate may be quite low, but when it comes to overall mixture of these two things, we believe 80 to 85% should be an appropriate number when you have a mixture of both ischemic as well as non-ischemic cardiomyopathy. There will be probably 15% of the patient when you take the whole substrate of CRT population where you may have a suboptimal correction, but 25% is a overinflated number.
So thank you so much, SS.